Welcome to AETCM, the emergency medicine channel. Today let us discuss about initial evaluation management of a common infection in emergency room. This discussion includes antibiotics also. So we know that there are different types of infection can come to emergency room. It can be like a simple upper respiratory tract infection, pneumonia, urinary tract infection, cellulitis, complicated infections like spontaneous bacterial peritonitis, meningitis, encephalitis, pyelonephritis. So many infections can come to emergency room. So when the patient come with an infection with history, sometimes we will get a possible source of infection, sometimes we may not get. So we have to do some investigation to know what type of infection he is having, where is the infection. So many investigation has to be done. So some of the investigations like blood sugar. So when the blood sugars are very high, that is an area for bacterial growth. So if the blood sugars are very high, and the bacterial growth can be very it's a favorable conditions for most of the infections to grow. So like urinary tract infection, if the blood sugars are very high, urine contains large amount of sugar and the growth can be very fast. And in conditions like diabetic ketoacidosis, HHS, all can be precipitated by an infection. So they have a mutual relationship. Infection increases sugar, sugar increases infection. And hypoglycemia is another problem in many infections, like a patient who is having liver disease or patient is having severe infection with liver involvement can have hypoglycemia. Infections like malaria, dengue fever can have spontaneous hypoglycemia. Many drugs used in infections can precipitate hypoglycemia. So many complications can be there in patients. So blood sugars are very important. Next one is inflammatory markers. So commonly used inflammatory marker is CRP. CRP is elevated in all types of inflammation, whether it is infection or simple inflammation, CRP will be elevated. Other positive inflammatory markers are serum ferritin, serum fibrinogen, ESR. They are all positive inflammatory markers. They increases when there is an infection or inflammation. But a negative inflammatory marker like albumin is very important. Albumin levels, you can see many patients who is having severe sepsis, albumin levels are low. That is because the vascular leak syndrome. So albumin is a negative inflammatory marker. Another important investigation is ABG. You can see many patients who is having infection, they can have acidosis. Acidosis can be due to renal failure, it can be due to liver failure, it can be due to lactic acidosis, hypoperfusion induced acidosis, diabetic ketoacidosis. So many varieties of acidosis you can see in infections. Rarely some patients can have alkalosis also, like respiratory alkalosis because of acute lung infection. They can have initially respiratory alkalosis. So ABG is very important. So to know whether the pH, PCO2, PO2, lactates, and many newer ABG machines can pick up electrolytes and creatinine also. So that also will give a very good insight about patient's electrolyte imbalance. Creatinine, you can see many patients who is having infections, especially urinary tract infection, pyelonephritis, you can see creatinine is elevated. And some infections due to sepsis, hypoperfusion, creatinine can be elevated. Severe hypotension, shock can induce pre-renal failure. So urea also will be elevated. So urea creatinine value indicates renal involvement, whether it is pre-renal or renal. Renal involvement will be confirmed by creatinine and urea. Creatine kinase is another enzyme, that is a muscle enzyme, that will be highly elevated in infections like leptospirosis. So that also we can do. CKMB is cardiac enzyme, creatine kinase MB factor. That will be elevated in sepsis induced myocarditis or infection induced myocarditis. So that also can be done. Now coagulation abnormalities, you can see prothrombin time INR, APTT. They all are prolonged in most of the infections. You can see when the liver is involved, DIC occurs, these parameters are elevated. Some patients who is having severe DIC, fibrinogen levels are low. But you have to remember one thing, fibrinogen levels can be high in many infection because it's an inflammatory marker, it's a positive inflammatory marker. So fibrinogen can be elevated in many inflammatory and infectious condition, but if the patient go to DIC, it will be very low. So a low fibrinogen level in a infection is a serious issue. So we have to address that issue and take it as DIC and treat it properly. LFT hyperbilirubinemia. Hyperbilirubinemia can be due to a jaundice, that is prehepatic jaundice, hemolysis. Many infections like pneumonias, like especially atypical pneumonias and severe sepsis can have hemolysis, and patient can have elevated bilirubin level. Liver involvement also produces elevated direct hyperbilirubinemia, SGOT, SGPT elevation. Many viral infection, hepatotropic virus, they can have very high levels of SGOT, SGPT. Leptospira can have high levels of SGOT, SGPT. Adrenal insufficiency is seen in many infections including tuberculosis. Adrenal insufficiency can be due to the involvement of adrenal gland in sepsis, tuberculosis and all. So patient can have hypotension, shock, so they may not respond to fluid or noradrenal, they need steroid therapy. So random cortisol level can pick up adrenal insufficiency in infectious cases. Other investigations, CBC should be done. We can see many patients who is having severe sepsis, initial phase of sepsis, if they have severe dehydration, hemoconcentration occurs, hemoglobin will be elevated, hematocrit will be elevated. Patient can have hemolysis, blood loss from the intestine, can have anemia. Patient who is having bacterial infection can have leukocytosis, WBC count can be elevated. But rarely infections like enteric fever can have normal WBC or low WBC. This is one bacterial infection very common in our country, enteric fever or typhoid fever. Their WBC counts are actually normal or low. Most of the other bacterial infection, it is elevated. Platelets are very typical. Most of the infections can reduce the platelet. Like most of the viral fevers, definitely they can have low platelet. But thrombocytopenia is classically seen in dengue fever, leptospirosis, malaria. These are the three important infections you can get thrombocytopenia. Now urine culture, pus culture, pus gram stains, all these things are also important. Like cellulitis, if you take the pus for gram stain, immediately you will get a report whether it is a gram positive cocci or something else. If it is gram positive cocci, then it is streptococcus or staphylococcus. So that's a very important investigation, can be done in any emergency room or can be done with the help of a pathologist or a microbiologist. Immediately we can get the report, gram staining. X-rays are very important. We routinely do X-ray chest in most of the patients. We can see whether pneumonia is there, consolidation is there, aspiration is there, any coexisting conditions like bronchiectasis is there. Other X-rays, mainly we do abdominal X-ray to see paralytic ileus, renal stones, all these things. Procalcitonin is one important sepsis marker. Many bacterial infection, procalcitonin will be elevated. For example, if patient is having bilateral pneumonia, normally we think that it can be due to viral infections. But in that patient, if the procalcitonin levels are elevated, we have to think that it is a bacterial infection. So procalcitonin is a diagnostic tool for bacterial infection, and it is also a prognostic marker, because after getting procalcitonin, high procalcitonin, we can start antibiotic. After 2-3 days, if the procalcitonin levels are very normal, that means patient has responded to your antibiotic, and if you want, you can de-escalate the antibiotic. So procalcitonin is a very good tool in bacterial sepsis. There are other markers. They are not very very important for today's clinical practice, because they are not available everywhere. They are all in primitive states. There is a triggering receptor expressed on myeloid cells, CD64 and polymorphonuclear leukocytes, CD14 subtypes, that is presepsin. Presepsin is available in some centers but not everywhere. Other interleukin levels also we can test in many infections. Interleukins, actually they are inflammatory markers. They will be elevated in many infections and inflammation. So interleukin can also be done in patients who is having sepsis. Now, when we talk about 1 hour bundle, it is very important that to treat the patient, that is a golden hour in any sepsis patient or any infectious cases, we have to start treatment as soon as possible in emergency room. So, whenever patient come to emergency room, we take care airway, breathing, circulation. We put 2 IV lines. We start fluids if the patient is having hypotension. We start noradrenaline if the patient is having refractory hypotension. Steroids can be given. But however, the major problem in infection is the pathogen, whether it is bacteria, virus or fungus, whatever it is. We have to treat that organism first. So, along with the management for airway, breathing, circulation, we have to initiate antibiotics also. So, we need to have good grip on antibiotics, like where all it is indicated, what is the coverage of antibiotics. So, all these things are very important for a emergency physician. So, administration of antibiotics should be done within 1 hour of the sepsis recognition. If a patient come to emergency room and if you are suspecting a sepsis, you try to find out the focus. According to focus, you can start empirical antibiotic. Suppose you are not able to localize the focus, then other empirical antibiotics for sepsis also you can give. But whatever it is, in 1 hour if you start antibiotic, then the outcome is very, very good. Now we can see first the most important problem in emergency room is upper respiratory tract infection. That is the most important problem everywhere, whether you take adult OPD, pediatric OPD, everywhere URTA is the most important problem. URTAs, we all know that it is mostly viral infection. Viral infections may not require any treatment. Most of the viral infections does not require any treatment. But if you are suspecting strongly tonsillitis or some gram-positive infection, you have to treat the patient with gram-positive coverage. You can give amoxicillin, you can give augmentin, you can give azithromycin, you can give doxycycline. So, depending on the severity, we can select lot of drugs, but it is predominantly gram-positive infection like sinusitis, pharyngitis, laryngitis, tonsillitis. If you are suspecting a bacterial infection, then better go for a drug which cover gram-positive cocci like streptococcus or other types of gram-positive infection. Like you can give amoxicillin, clavulanic acid, that is augmentin, azithromycin, doxycycline. All these things are very important or very useful. That the most commonly used drug is always azithromycin, roxithromycin, clarithromycin, like that. Advantage of azithromycin is azithromycin 500 mg once daily is enough, and only for 3 days it is required. Post antibiotic effect is there, so it may act for another 5-6 days. So 3 days 500 mg once daily is a very reasonable dose for azithromycin, and most of the patients will require only that much antibiotic, because most of the infections are viral. Even if you don't give antibiotic, they recover without any problem. But if you suspect a bacterial infection, azithromycin is a good choice. The problem with other drugs, like if you go for amoxicillin, it has to be given 3 times daily, augmentin 3 times daily, doxycycline first day 200 mg on the first day, and 5 days 100 mg OD is enough. So dose advantage, duration advantage, all are for azithromycin. But however, depending on your clinical experience, you can select one of the drug which covers gram-positive infection. But remember that most of the infections are due to virus. They may not require any treatment for that. Now, lung infection including pneumonia, it can be, you can divide the lung infection into major two classical group. One is a lung infection without a previous pre-existing lung disease. Another one is a lung infection in a patient who is having pre-existing lung disease, like patient who is having cystic fibrosis, patient is having COPD, patient is having bronchiectasis. They are all pre-existing lung disease. And a patient who is having fresh patient who never had a lung infection, or first time is coming with a community acquired lung infection. The basic difference between these two are, if it is a first time community acquired infection, they are mostly gram positive infection. Mostly, it is not 100%, mostly gram positive infection. But a pre-existing lung disease with lung infection are gram positive or gram negative infection. So that's why again you can select your antibiotic. If it is a previous healthy lung, you can go for azithromycin, you can go for augmentin. you can go for doxycycline, because all these drugs mainly covers gram-positive infection. And azithromycin, you all may be knowing that it is an anti-inflammatory drug in the lungs. In the lung parenchyma, it has got an anti-inflammatory action, but it takes some time to produce anti-inflammatory action. But even then, it is a very useful drug in lung infection, and it is once daily for 3 to 5 days. 3 days minimal infection. In a severe infection, you may give up to 5 days. The advantage of this drug is it may be that post-antibiotic effect is there for another 5-6 days. So, azithromycin 500 mg, clarithromycin 250 mg BD, doxycycline 200 mg first day, then 100 mg OD can be given, or you can go for augmentin. It has got a better coverage for gram-positive cocci and moderate coverage for gram-negative infections. But in a patient who is having pre-existing lung disease, then levofloxacin or moxifloxacin are the drug of choice, because we know that the infection can be due to gram-positive or gram-negative infection. So we cannot use only gram-positive antibiotic coverage. So we go for moxifloxacin 400 mg OD or levofloxacin 750 mg OD. Levofloxacin is, we know that levofloxacin is available as 500 mg tablets, but we have to give 1.5 tablets daily for any normal weight person. Other drugs like amoxicillin, clavulanic acid can be given, that is augmentin 625 mg TID can be given. If you are giving injection, then 1 gram BD can be given. That is also available. These augmentin injections are available in that rate. So that is a main treatment in OPD basis patients. You are not admitting, you are discharging the patient. For a stable patient who is having no previous lung disease, you give drugs like augmentin, azithromycin or doxycycline. Now, lung infection, if it is severe, again, if we want to admit the patient, then you can again go for levofloxacin, moxifloxacin injection and ceftriaxone or ampicillin sulbactam combination or ertapenem plus macrolide combination. And if it is a severely infected patients, I'll tell there are multiple options during that period. What we have to remember is, whenever we are admitting a patient to our ICU from emergency room, empirically when we are covering the lung disease, we have to give both gram positive and gram negative coverage. So if you are giving, if you are working in a primary setup, you can give crystalline penicillin and drug like which covers gram negative infection, that is quinolones, or azithromycin, that is also covers gram positive infection. So when we are treating patients in a primary setup, we can give crystalline penicillin. That's a basic antibiotic which covers gram positive infection. But if you are treating a severely sick patients, crystalline penicillin may not be enough, because most of these infections are resistant to penicillin. So we will have to go for higher antibiotic which covers a deeper like range of infection. We have to go for quinolones, respiratory quinolones. Again, moxifloxacin or levofloxacin can be started. If you are giving crystalline penicillin, always cover, crystalline penicillin basically covers gram positive infection. You have to add a gram negative coverage to that. You can give gentamicin, amikacin, they all covers gram negative infection, or ceftriaxone, it also covers gram negative. So many doctors give like that, 1 gram positive coverage, 1 gram negative coverage. That is, if you are giving CP, you add ceftriaxone or gentamicin, amikacin to that CP. Or if you simply go for moxifloxacin and levofloxacin, that covers most of the gram positive and gram negative infection. It also covers atypicals and anaerobes. So that is the advantage of moxifloxacin, levofloxacin. But if the patient is having severe infection, sepsis, then you will have to go for higher antibiotic like piperacillin tazobactam or meropenem, like that you can go. Now, if you are suspecting pseudomonas infection like pre-existing severe lung injury like cystic fibrosis or bronchiectasis, then you cannot go for the previous drugs what we discussed. We have to go for piperacillin tazobactam, cefepime tazobactam, imipenem cilastatin, meropenem, like that. You have to select higher drugs. If MRSA is suspected, then we have to add vancomycin. Now, many patients who is having severe pneumonia with mucus plug obstruction, if you are seeing collapse of the lung, then they require bronchoscopy to clear the secretions from the bronchus. That is also needed in emergency room itself. Chest physiotherapy is another important area where the patient postural drainage, percussion on the lungs, all these things are very important to remove the sputum from the chest. Now, if we are treating a diarrhea patient, we can see many doctors treat with ciprofloxacin tinidazole combination, ofloxacin tinidazole combination. That is not required actually. When we are treating simple diarrhea, most of the time we also know that it is due to the virus. It is not. Most of the infections are not due to bacterial infection. Bacterial infection will have high degree fever, blood in the stool, severe abdominal pain. But most of the cases we start empirical antibiotic. We start ciprofloxacin with tinidazole. Here tinidazole is actually not required. Tinidazole requires in amoebiasis, giardiasis and all. Metronidazole or tinidazole is required. But if we see the diarrhea, we can know that it is not due to an amoebic cause or giardia cause. Clinically, it may not justify the use of tinidazole. Rifaximin is very useful drug in this routine diarrheas because it's a non-absorbable antibiotic. It is a gut sterilizer. Most of the gram-negative organism can be removed by this rifaximin. So you can give 500 milligram BD can be given. And some severe diarrheas like cholera, you can give doxycycline. So, and probiotics also very, very important in patient who is having diarrhea, because when we are using higher antibiotic, the routine flora, normal flora in our stomach will be removed. So, to replace that, we have to give probiotics. So, rifaximin is a very useful drug in routine diarrheas. If the patient is having severe symptoms, go for ciprofloxacin because that is a gram-negative quinolone that act well in the intestine. If you are suspecting enteric fever, go little higher. You go for ceftriaxone. If the patient is sick and hypotension, go for piperacillin tazobactam or meropenem or imipenem cilastatin. Metronidazole or tinidazole or secnidazole, or they are not at all very good choice in acute diarrheas. Without knowing the organism, if you are giving metronidazole, tinidazole, there will be severe metallic taste, gastritis because of these drugs itself. So, if the patient is not tolerating these drugs, better to stop and put them on only on rifaximin or ciprofloxacin for diarrhea. But remember, most of the diarrhea is in children, and some of the adult cases are due to problems in the food, not due to the infections. It's a written food or due to viral infection, they develop diarrhea. They may not require antibiotics at all. Other important supportive therapy you have to remember is the patient is having dehydration, give ORS tablets in a child and adult both, and ringer lactate is the fluid of choice in diarrhea and vomiting. Many patients who is having diarrhea, especially in children, we need to give zinc syrup. So all these things we will deal when we are discussing a case of diarrhea. Now, infective endocarditis, we all know that it is an infection to the cardiac valves. So, when we are treating an infection to the cardiac valves, especially in emergency room, we will not be knowing what is the organism. So, to know the organism, we have to take 3 blood culture samples, 3 sets of blood culture. One set is 2 samples, 3 sets of blood culture samples from 3 different sites at 3 different timings we have to send. Then we have to prove that at least 1 or 2 samples have same organism. Then only we can confirm the diagnosis. We can go for transesophageal echo to confirm vegetations. But here the most important thing is when we are starting empirical therapy, again we have to cover gram positive cocci, MRSA and gram negative organism. So that's why most of the guidelines say that you start ceftriaxone 2 gram IV OD for 4 weeks and vancomycin 15 mg per kg IV BD for 4 weeks. Here also the main principle behind treatment is you add one drug for gram positive cocci or gram positive infection, another drug for gram negative infection. This is empirical therapy. That means before knowing the culture, we initiate the treatment like that. Here first guideline you can see penicillin, crystalline penicillin with gentamicin, crystalline penicillin with ceftriaxone, ceftriaxone with vancomycin. Vancomycin covers gram positive, ceftriaxone covers gram negative. So that is the principle behind treating this infective endocarditis. Spontaneous bacterial peritonitis, that is patient who is having ascites and low albumin in the ascitic fluid. If they come with deterioration in the symptoms or abdominal pain, increased abdominal distension, we always suspect spontaneous bacterial peritonitis. Two important antibiotics we have to give. One is rifaximin for gut sterilization. Second one is ceftriaxone or cefotaxime for treatment for suspected SPP. Ceftriaxone, cefotaxime, all are third generation cephalosporins. They act mainly against gram negative infection. E. coli is the most common infection producing bacteria in the SBP. So we start with ceftriaxone or cefotaxime. Some patients may require higher antibiotic like piperacillin tazobactam, meropenem, or cefepime tazobactam, cefporaxone sulbactam. All these things also can be used. Now, skin infection, the most important problem is two important organisms, that is gram positive cocci like streptococcus, staphylococcus, and other gram negative organism anaerobes. So to cover all these things, initially when we are getting the patient, first time if they are coming to the hospital and there is no previous hospitalization for cellulitis, what skin infection, whatever it is, mostly they are gram positive cocci, they may respond to penicillins. So they are called as methicillin susceptible Staphylococcus aureus. In that the best drug for that group is flucloxacillin or cloxacillin. Flucloxacillin available nowadays. We can give 1 gram IV QID. Doxycycline can be given, but the better drug is always flucloxacillin. If the patient is having repeated infection or previous culture shows MRSA, then better to go for vancomycin, tigecycline, daptomycin, dalavancin like. So vancomycin 500 mg QID or 1 gram BD can be given. So whenever we are suspecting severe skin infection, hypotension, shock, we have to suspect toxic shock syndromes. That means these gram positive cocci produces toxic material to that infected area that may come to the blood and produces toxic shock syndrome. To prevent that, we have to add clindamycin to the regime. So always add clindamycin when you are suspecting a severe skin infection and systemic extension of that infection. Now, empirical antibiotic therapy in diabetic foot is also similar to the we discussed in the previous slides. If the patient is having an acute infection, always think about gram positive infection. Flucloxacillin will be a very useful therapy in acute phase. But if the patient is having repeated infection, past history is there, then better to go for a higher antibiotic like ticarcillin, clavulanic acid, piperacillin tazobactam plus clindamycin, and you can add an gram negative coverage also for better penetration. So in a severe infection, we go for higher antibiotic like piperacillin tazobactam plus clindamycin. In a mild infection, we go for flucloxacillin, doxycycline, ampicillin sulbactam combination. Urinary tract infection, very, very important. Any patient with urinary tract infection, most of the time it is gram negative infection. We can see E. coli, Klebsiella, all these organisms in culture. So routinely we give ofloxacin, ciprofloxacin, drugs like that. And some patients who are very sick, we give ceftriaxone IV. And sometimes if the patient is having any allergy to that penicillin group, we can go for aminoglycosides like gentamicin can be given. Another important drug in that group is fosfomycin. Fosfomycin advantage is it can be given as oral or IV. 3 gram IV single dose is enough in most of the infections. Single dose, if we give, most of the patients will respond to that single dose therapy. Some patients may require additional 1 or 2 doses, so that can be given. And severe infection, hypotension, shock and all, we have to give meropenem or piperacillin-tazobactam. Ertapenem is a carbapenem group that can be given in severe urinary tract infection without septicemia. Ertapenem should not be used in a patient who is having severe septicemia. It can be used as an OPD based therapy for a severe urinary tract infection. You have to always check the previous culture reports when we are treating urinary tract infection. What was the organism previously, whether it is different types of organism coming in the cultures or the same organism is coming in the culture. ESBL positive. ESBL positive means you cannot use ceftriaxone, you cannot use another like augmentin, something like that. You have to go for higher antibiotics or quinolones. Meningitis, the basic principle behind meningitis treatment is you give 1 gram positive coverage, 1 gram negative coverage. Here the most useful coverage will be ceftriaxone with vancomycin. And patient who is an elderly individual, you can go for ampicillin, sulbactam additional to this to cover the listeria. So ceftriaxone with vancomycin, or directly go for meropenem 2 gram IV 8th hourly. That is used only if you are suspecting a severe infection. Otherwise, most of the meningitis you require to give only ceftriaxone or CP, crystalline penicillin with ceftriaxone or vancomycin with ceftriaxone. Most of the international guidelines say you go for vancomycin with ceftriaxone. If you are suspecting an elderly individual with meningitis, listeria, then go for ampicillin to the regime. Many patients who is having meningitis, we have to give dexamethasone because a capsulated organism, when it is killed by the antibiotic, that produces immense reaction in the CSF. To prevent that, we have to give dexamethasone. Dexamethasone should be given before use of antibiotic, before starting antibiotic you give. So when we are suspecting meningitis, give dexamethasone, take the patient for CT or MRI, whatever it is, and immediately start antibiotic. So before half an hour of any antibiotic, initial antibiotic, better to give dexamethasone. Once you rule out gram-positive infection in the brain, you can discontinue the therapy. Febrile neutropenia, again, febrile neutropenia, we have to cover 2 important organisms. One is MRSA, other one is severe gram-negative infection like Pseudomonas infection. So we have to give cover for that. You can give vancomycin, piperacillin-tazobactam combination, or directly go for any carbapenem injections. Now, many infections in emergency room actually can be due to viral infection, like you have bilateral pneumonia, it can be H1N1 or COVID infection. Unnecessary using antibiotic for that is not necessary. So you go for antiviral treatment. And infections like leptospirosis, we can see many doctors use higher antibiotics. That is not required. You can give doxycycline, you can give amoxicillin, you can give augmentin, you can give azithromycin. Any of these smaller drugs will cover leptospira. No need to go for a higher antibiotic. In fungal infection, again you can get bilateral pneumonia in fungal infection. No need to go for antibiotic. You have to go for ideal antifungal drugs, either select a lower group of drugs or a higher group of drugs like capsophancin. So they are also antimicrobials, but they are not antibiotics. So we have discussed about some common infections in emergency room, the initial management of emergency room, some initial empirical antibiotic therapy in emergency room. But what we have to understand is, if you are, suppose you start antibiotic in a condition and if you rules out an infection, immediately stop the drug. Unnecessarily continuing antibiotic or without rationale, if you are continuing antibiotic, there is a high chance for drug resistance. So better to stop the drug if it is not required. So antibiotics are specialized drugs. They should be only used in specific indications. Unnecessarily using higher antibiotics in a smaller infection should not be should not be done in any emergency room. If required, the most appropriate antibiotic for a short period can be initiated by the emergency physician, and depending on the expertise, the infectious disease specialist can change it, or depending on the culture report or procalcitonin levels, we can easily de-escalate the antibiotic. Thank you.